So today we're going to be talking about Chapter 9, which is personality disorders. In this chapter, we're going to be talking about some of the main personality disorders. There are more than this, but these are the ones that are most typically talked about. They're borderline personality disorder, narcissistic personality disorder, avoidant personality disorder, obsessive compulsive personality disorder, and schizotypal personality disorder. So when we talk about personality, what does that mean? So our personality determines how we feel, interact, and perceive events. People generally think that personality is innate, that we are born this way. This is who we are. So a personality trait, when we discuss that, is a pattern of behavior, thought, and feeling that is stable across time and across many situations. So this is not something that we anticipate will change. So it's not necessarily like depression where somebody can get it and then they can get better and worse. This is somebody, a person is this way. This is their personality. A personality disorder is when there's a fundamental deficit in a person's personality in the sense that they don't know who they are or they have trouble with who they are, and it also impacts their ability to have relationships. And this is above and beyond something like social anxiety disorder. This is something about them or their personality that causes this. The thing about personality disorders is that many times the person is actually not distressed by their personality disorder. It's actually distressing to those around them because this is who they are and they are okay with it generally. So, steps in diagnosing a personality disorder. I can tell you clinically how I diagnose the personality disorder. In addition to obviously all the formalized methods, which we'll talk about here, there's an odd feeling that you get when you're with somebody with a personality disorder. They make you feel a little bit uncomfortable. There's a kind of a sense that something is a little bit off. You can't quite put your finger on it. And that generally is an indication that you need to kind of think that possibly a personality disorder is present. So in assessing a personality disorder, you have to determine the individual's level of functioning in terms of their sense of self or their relationship with others. And generally, people with personality disorders function very well in the sense that, they're able to hold down jobs, they don't feel a lot of distress. And then you have to determine whether the individual has any pathological personality traits. So those are the ones that are impacting their lives in some way. So even if it doesn't bother them, like, do they push everybody around them away? Are they unable to maintain jobs because of their personality disorder? Are they getting in trouble with the law because of their personality disorder? And then you can determine whether the individual meets criteria for a DSM personality disorder. So there are some core personality traits such as negative affectivity. So this is the extent to which people tend to be even-tempered and calm, secure, and able to handle stress. So people oftentimes who have personality disorders don't have these, or they can't necessarily maintain a calm demeanor. Detachment. These are the extent to which people are appropriately outgoing and trusting of other people. So some personality disorders kind of have people withdrawn. But again, it's different from social anxiety disorder in that they do not feel distressed. Antagonism. These are, it can be both positive and negative. So is a person, positive antagonism is honesty, appropriate modesty, concern. Negative is deceitfulness, grandiosity, or callousness. And then disinhibition, the tendency to be responsible, organized, and cautious. On the contrary, they can be impulsive, risk-taking, and irresponsible. And there's psychoticism. There are personality characteristics that are, rare, but some people do have these kind of more psychotic traits. So one of the most common personality disorders that you might hear most frequently about is called borderline personality disorder. And it was called borderline personality disorder because it was said to be on the border between psychosis and neurosis. We now know that there's a kind of a biopsychosocial development to it, so people are predisposed to develop borderline personality disorder, but then because of their invalidating environment, they then go on to develop it. But just to kind of give you a description of it, these are the out-of-control emotions that can't be smoothed, the hypersensitivity to abandonment. So, when a relationship breaks up or there's the fear of somebody leaving them, there's this kind of like this disproportionate attempt to kind of get that person back. Tendency to cling too tightly to other people. A history of hurting oneself. So this is very common. About 70% of those with borderline personality disorder actually engage in self-harm behaviors. There's also an unstable self-concept and mood. So you'll see strong mood swings both in terms of depression and anger. Also, they have a difficulty figuring out who they are, so their sense of self changes and vacillates frequently. There's a high degree of antagonism. They get in fights very frequently with other people, and a lot of depression and negativity. There's a high degree of depression in people with borderline personality disorder, and many of those who have the disorder will go on to make a suicide attempt, and about 10 to 15% of those individuals, the attempts will end up being fatal. So here are the DSM-5 general criteria for personality disorder. So significant impairments in sense of self and relationships, and one or more pathological personality domains or trait facets. So those are the ones that we just discussed previously. The impairments in personality functioning and the individual's personality trait expression are relatively stable across time and consistent across situations. So this is where the personality aspect of it comes in, that it's pretty much since birth the person has behaved this way. The impairments in personality functioning and the individual's personality trait expression are not better understood as normative for the individual developmental stage or socio-cultural environment. So this is basically what it means is, obviously different periods of time, there are different behaviors. So it's not the typical teenage rebellion, or it's not a culturally sanctioned types of behavior. The impairments in personality functioning and the individual's personality trait expression are not solely due to direct physiological effects of a substance. So it's not due to medication or drugs or general medical condition like a severe head trauma. So we already talked about some of the benchmarks. So some of the it's characterized, the borderline personality, by fundamental deficits in identity and interpersonal relationships. So there's a lot of problems with relationships. Oftentimes people with borderline personality disorder will go from therapist to therapist because they sometimes idealize their therapist, thinking the therapist is the best person ever. Or on the other hand, the therapist is like the worst and they hate them and they fire them. It's very common that therapists are fired by clients with borderline personality disorder. There's unstable self-concept, as we discussed, with periods of extreme self-doubt alternating with periods of grandiose self-importance. And so there's just really this vacillation from self-loathing and self-hatred, and you see a lot of the cutting and the suicide during those periods to kind of periods of feeling really important, feeling really good. And so it's almost, sometimes they get misdiagnosed as individuals with bipolar disorder as well. A typical movie presentation, although not necessarily 100% accurate, but is Glenn Close in Fatal Attraction. They said that she would be a character with borderline personality disorder, as well as Angelina Jolie in the movie Girl Interrupted. The theories of the development of borderline personality, the cognitive theory is that there's childhood abuse, neglect, and instability, which contributed to deficits in emotion regulation and attaining a positive sense of self. And they have not been able to maintain a stable identity. So, if the people that are supposed to be taking care of you are not validating you appropriately, therefore your self-concept can't properly develop. There's a high level of childhood abuse, especially sexual abuse, in those with borderline personality disorder. According to psychoanalytic theory, people never learn to fully differentiate their view of themselves from their view of others, which makes them extremely reactive to other people's opinions of themselves and possible abandonment. So one of the hallmark features of those with borderline personality disorder is really this interpersonal sensitivity, and so they can be slighted very easily, and you have to be very cautious about what you say because they can take it very personally. Neurobiologically, they find that those with BPD have smaller amygdalas and hippocampus, which results in difficulty regulating emotions and moods. There are structural and metabolic abnormalities in the prefrontal cortex, which results in dysregulation of emotions and problems controlling impulsive behavior. So you often see impulsive behavior. So when individuals with BPD get upset, their reactions are very extreme, like very extreme anger, the self-cutting, the suicidal behavior. And there is some evidence that these symptoms are heritable and that those with BPD, it kind of runs in families. So the treatment for BPD is what's called dialectical behavior therapy. This was developed by Marsha Linehan at the University of Washington. This is known as DBT. Those of you who continue on with psychotherapy will probably hear a lot about DBT because it's used very commonly in the field for, they're using it for a lot of different disorders now, but it was developed for those with borderline personality disorder, especially to decrease the self-harm behaviors, suicide and self-mutilation. So DBT focuses on gaining a more realistic and positive sense of self, learning skills to solve problems and regulate emotions, and to correct this black or white thinking that is very common in those with BPD. Those in a cognitive therapy model, you want to they have a program called STEPS, which is Systems Training for Emotional Predictability and Problem Solving. And they show improvement in negative affect, impulsivity, and functioning. DBT, they found great results in terms of decreasing hospitalizations, self-harm behaviors, suicidal behaviors, and after about a year of treatment, they also depressed mood was significantly lower. Psychodynamically oriented therapies focus on transference. So they use the relationship between the patient and the therapist. So transference refers to the relationship, so transfer the feelings between the therapist and the client. So you focus a lot on session on the relationship itself and how to work through that. Mentalization-based therapy provides patients with validation and support, and it helps them appreciate alternatives to their own subjective sense of self and others, and so giving them, other perspectives on their mood. They also are often prescribed mood stabilizers like antidepressants and antipsychotic medications, although there's no set cocktail for those with BPD, because oftentimes it's really more of teaching coping strategies to help them regulate their emotions. So moving on with narcissistic personality disorder, this is when people have an overwhelming sense of self-importance and arrogance. They seek constant, unwarranted admiration from others. And then they rely on self-evaluations and seek dependency on others who are weak and dangerous. And so we see high rates of substance abuse and mood and anxiety disorders. So according to psychoanalytic theory, these are people who actually have very low sense of self-esteem, and then they kind of defend against it by putting on this sense of grandiosity. But it's actually very, kind of putting off people that are always kind of saying, I'm better than you, and thinking Donald Trump might be somebody who would be considered to be a narcissist because he's always telling other people how wonderful he is. According to cognitive theory, so narcissism is a result of unrealistic positive assumptions about self-worth developed because of indulgence and overvaluation by others during childhood. So these individuals were spoiled and people kept telling them that they were wonderful even though they weren't necessarily as wonderful as they were told. Not to say they don't have good traits. But they developed the belief that they are unique or exceptional as a defense against the rejection by important people in their lives. And so because they've had these negative experiences, and there is like a sense of self-hatred is what's been hypothesized, that these people then project them that they're much better than other people. So there are really not any empirically or evidence-based treatments that have been shown to be really effective in changing people with narcissistic personality disorder. But cognitive techniques help to develop better realistic expectations of their abilities, sensitivity to the needs of others, and learning to challenge their initially self-aggrandizing interpretations of situations. So basically, you're teaching them how to behave in society so that other people aren't put off by their inflated sense of self. But the majority of people who have narcissistic personality disorder do not seek treatment because it doesn't bother them, because they feel really good about themselves, and therefore, why seek treatment when you are so wonderful? Avoidant personality disorder. This is kind of, sometimes we confuse avoidant personality disorder and social anxiety disorder, but this is more people who stay away from people. They have low self-esteem or prone to shame, and they're extremely anxious about being criticized by other people, which is similar to those with social anxiety, but they generally avoid contact. But what we see that's different is that this doesn't really respond very well to treatment, and it's been kind of characterological since childhood. So these are kids that are born this way, and there's just a lot of negative affectivity, there's detachment, there's not really the sense of bonding. Like in social anxiety disorder, there's oftentimes they do have some good relationships, but they're just scared of certain social situations. Biologically, they see some similar genes in those with avoidant personality disorder and social anxiety disorder, so there definitely is some overlap. We don't see any strong relationship to sexual or physical abuse in childhood, but we do see some emotional neglect in that the children's emotional needs are not being met. According to the cognitive theory, avoidant personality has developed because of rejection by important others early in life, and therefore they don't even try to form these relationships or these connections in the future. So cognitive behavioral therapies try to expose individuals to social situations, give them social skills training, challenging negative automatic thoughts. But because, again, this is more of a personality disorder than A disorder like social anxiety disorder, you don't see dramatic change because this is who the person is, and it's hard for them to change their fundamental sense of self. They also do take serotonin uptake inhibitors. So serotonin reuptake inhibitors can also be prescribed, but again, we've not had a lot of success in treating avoidant personality disorder because, again, it's a personality disorder. It's part of the individual. Obsessive compulsive personality disorder, this is very similar to obsessive compulsive disorder, but it's something, again, that was present since birth, and it's not bothersome to the extent that OCD is. It's more kind of a personality trait, like an extreme type A type of personality. You see the highly compulsive perfectionistic people. There's a lot of like glass half empty kind of thinking. They share a lot of features with obsessive compulsive personality disorder. It's often been said that Monica on Friends, for those of you who ever watched the show Friends, although that might be before your time now, but she was kind of an OCPD kind of person, obsessive compulsive personality disorder. So according to cognitive theory, these people harbor strong, rigid beliefs. There's some genetic factors that are similar to those found in OCD, and there's a history of physical neglect, that their needs were not met, and they become kind of, they overcompensate for that. So treatment for OCD revolves around supportive therapies, assisting in overcoming crises that require treatment. So sometimes when things go awry, they can't handle it because they have to have this very rigid way of thinking. They don't think outside the box or can't problem solve. And behavioral therapies focus on decreasing compulsive behavior, so it would be very similar to the exposure therapies that we see with those with OCD. Schizotypal personality disorder, these are similar to the symptoms of those with schizophrenia, but in a milder form. So these individuals might have unstable or disorganized identities. There might be social isolation. They might be uncomfortable in interpersonal interactions. There's kind of a detachment and some psychotic type of thinking, but not to the degree of somebody with schizophrenia. These individuals often can maintain jobs where they would work at home, for example, like a computer type of person. These individuals often come across as kind of weird, or these would be kind of like the crazy ladies that you see sometimes around. We had one in our old neighborhood. It's not necessarily just women, it could be men as well. But you do see paranoia, distorted ideas of reference, odd beliefs or magical thinking. And then beliefs, you see illusions. They're not hallucinations, so therefore they do not meet criteria for schizophrenia, but they do have some sensory experiences that are outside the realm of normalcy. There is evidence that this is genetically transmitted, and that it's associated with a gene that regulates the NMDA receptor system. They also find difficulties in verbal fluency. There's also dysregulation in the neurotransmitter dopamine, which is the one we saw that was also implicated in schizophrenia. We also see that there are histories of childhood adversity reported among those with schizotypal disorder, so it's unclear, how much of that is related and how much of it is really biological. In terms of drug therapy, it would be the same as those with schizophrenia, antipsychotic, antidepressant, neuroleptics. And in terms of cognitive therapies, it would be kind of challenging some of these more odd beliefs. But again, this is more of a personality disorder, so the outcomes are not as, we have not really found anything that's super effective in treating these personality disorders. So in terms of an integrated model of personality disorders, we know that there's a biological predisposition to having a difficult temperament, perhaps, parenting that is harsh, critical, or unsupportive. There might be behavioral and emotional dysregulation, negative reactions from peers and adults, and then this can also then worsen these temperamental disorders and make it, more pathological. So these are really we don't know that much about personality disorders. They're hard to diagnose. There's a lot of, there's a lot of overlap in the diagnostic criteria, and so it's really unclear exactly, what these are in terms of the personality disorder as entities, and they're an area which require a lot more research. So that is the end of the lecture for today, and we'll be talking to you soon.